I want to start with a question that I think about more than most people would expect a doctor to think about. How many of the medications sitting in your cabinet right now have you ever truly questioned? Not the side effects listed on the packaging, those you may have glanced at once. I mean really questioned. Asked whether the way you feel on a given day, the way your mind works, the sharpness that seems slightly less sharp than it once was, whether any of that might have something to do with what you've been taking consistently, perhaps for years. Most people haven't asked that question, and I understand why. When a doctor prescribes a medication, there is an implicit message that comes with it. This is what you need. This is safe. Take it as directed. And the medication is often necessary. I'm not here to suggest otherwise. What I am here to suggest is that necessary and without consequence are not the same thing, and that after 60, when the body processes things differently than it once did, the conversation about what certain medications do over time, specifically to cognition, to memory, to the quality of thinking, is a conversation that happens far less often than it should. That's what I want to have with you today. I've been practicing medicine long enough to have watched certain patterns unfold so consistently that they've stopped surprising me, though they've never stopped concerning me. The pattern I want to describe goes something like this. A patient, often someone in their early to mid-60s, someone who is otherwise managing their health reasonably well, begins to notice that their thinking feels different, not dramatically different. Not the kind of different that makes them call someone in alarm, just a subtle dimming. Words that used to come quickly now arrive a beat late. Names they've known for decades occasionally require effort. A conversation from 2 days ago feels hazier than it should. The morning feels a little slower to come into focus. They mention this to a family member who says it's probably just age. They mention it at a doctor's appointment, almost as an aside, and the doctor notes it, perhaps orders some routine tests, perhaps reassures them that some cognitive slowing is normal with time, and the assessment is often correct. Some degree of cognitive change is a part of aging, but what doesn't always get examined closely enough is the medication list, the full picture of what this person has been taking, how long they've been taking it, how the individual medications interact with one another, and how the aging body, specifically the brain, responds to these compounds differently than a younger body does. I've seen this gap in the conversation too many times. A patient experiencing cognitive symptoms, a medication list that has grown over the years, and no one connecting those two things with enough seriousness. Not because anyone is negligent, because this is genuinely a difficult and nuanced area of medicine, one where the evidence is still developing, where individual variation is enormous, and where the benefits of medications often clearly outweigh the risks. But also one where more awareness, on the part of patients and, frankly, sometimes on the part of clinicians, could make a meaningful difference. Let me explain something about the aging brain that I think is essential for everything I want to discuss today to make sense. The brain at 60 is not simply a slightly older version of the brain at 40. The changes that occur over those decades are real and measurable. Blood flow to the brain decreases somewhat. The blood-brain barrier, the protective filter that determines what enters the brain from the bloodstream, becomes more permeable, more leaky, in ways that mean certain substances that would not have readily entered the brain in younger years can now do so more easily. The liver and kidneys, which are responsible for processing and clearing medications from the body, work more slowly. This means medications persist in the body longer, reach higher concentrations in the blood, and consequently exert their effects for longer than the prescribing information, developed largely through studies on younger populations, may reflect. The brain also becomes more sensitive. The receptors that medications act on, the chemical systems they interact with. These change with age in ways that can amplify the effects of certain drugs. A dose that produced a mild effect in a 50-year-old may produce a more pronounced effect in someone who is 70. And that amplification is not always desirable. In fact, it can produce effects that look, from the outside, exactly like the early signs of cognitive decline, when what is actually happening is a medication effect that nobody has examined. I want to pause on that for a moment because I think it's genuinely important. Memory changes, difficulty with focus, a sense of mental fog, slowed processing speed. These are all recognized features of certain medication effects, particularly in older adults. They are also recognized features of normal aging and of early neurodegenerative processes. The difficulty is that these categories overlap in presentation. They look similar. And without someone specifically asking whether the cognitive changes coincided with starting, increasing, or combining medications, the medication question may not get asked at all. Now, I want to talk about specific categories of medication. Not by name, in most cases, because I'm speaking generally, and because the same class of drug can have many different specific formulations and effects, but by what they do, and why their relationship with cognition in older adults deserves careful attention. I'll start with something that I think will surprise many people, because it covers a category of medications that are extremely widely used and that most people have never associated with memory or thinking. Sleep aids and anti-anxiety medications. In particular, a class of drugs called benzodiazepines, and certain medications that work through similar mechanisms, including some that are commonly prescribed specifically for sleep. These medications work, broadly speaking, by quieting the central nervous system. They reduce anxiety. They promote sleep. They are, for many people, genuinely helpful in managing conditions that significantly affect quality of life. I'm not suggesting they should not be used. But I am suggesting that when they are used regularly, over months and years, particularly in people over 60, something happens that deserves more attention than it typically receives. The brain, when exposed to these medications consistently, adapts. It adjusts its own chemistry to compensate for the sedating effect of the drug. The result, over time, is that the medication becomes less effective at its intended purpose. The person may find they need more of it to achieve the same effect, and simultaneously begins to produce effects that were not part of the original intent. Effects on memory encoding, on the ability to form new memories clearly, on recall speed and precision. These effects are not dramatic in the way that a stroke is dramatic. They are subtle. They are the kind of thing that a person notices as, "My memory isn't what it used to be," and attributes to age. And in some cases, age is part of the picture. But in other cases, in cases I've seen, reducing or discontinuing the medication, slowly and carefully and always under medical supervision, has produced a return of cognitive clarity that surprised the patient themselves. They hadn't realized how much had quietly changed. What I want you to hear in this is not alarm. I want you to hear a question. If you have been taking a medication in this category for an extended period, for sleep, for anxiety, for any reason, and you have also noticed changes in your thinking or memory, those two facts belong in a conversation with your physician. Not as an accusation, not as a crisis, but as a question worth taking seriously. The second category I want to discuss is one that will be familiar to many people in their 60s and beyond, because these medications are among the most commonly prescribed to this age group. Medications for blood pressure, and in particular, a subset of them. Most blood pressure medications are well tolerated and genuinely important. Uncontrolled high blood pressure is one of the more significant risk factors for cognitive decline over time, so the medication that controls it may actually be protecting the brain. I want to be clear about that. The relationship here is not simple. But certain types of blood pressure medication, specifically those that cross into the brain, which not all of them do, can, in some individuals and at certain doses, affect cognitive function in ways that are not always immediately recognized. Some people on these medications describe a flatness to their thinking, a sense that their mind is working through something slightly resistant, a quality of thought that they find difficult to articulate, but that differs from how they felt before the medication. This is not universal. Many people take these medications for decades with no noticeable effect on cognition. Individual variation here is real and significant. But the possibility exists, and it's one that I think patients deserve to know about, so that if they notice something, they have the framework to bring it up rather than attributing it entirely to age. There's also something worth understanding about blood pressure medications, specifically in the context of the older brain. The brain depends on consistent, adequate blood flow to function well. When blood pressure is too high, that flow becomes damaging. But when medication brings blood pressure lower than the optimal range for a particular individual, what's sometimes called overtreatment, blood flow to the brain can be reduced in ways that also affect cognitive function. The target for a 60-year-old brain may not be the same as the target for a 40-year-old brain. This is an area of active discussion in medicine, and it's one reason why regular reevaluation of medication targets and doses, not just prescribing and maintaining, is so important as people age. I want to move to a third area that I think is perhaps the most underappreciated of everything I'll discuss today: anticholinergic medications. I'm going to use that term because there isn't a simpler one that covers the category accurately, but I'll explain immediately what it means and why it matters. The body uses a chemical called acetylcholine as a messenger in the nervous system. Acetylcholine is involved in many things: muscle control, digestion, heart rate regulation. But it is also critically important for memory and learning. When medications block acetylcholine's activity, which is what the term anticholinergic means, they affect all the systems that depend on that chemical, including the brain's memory systems. What makes this category particularly significant is that it's enormous. The list of medications with anticholinergic properties includes drugs that are commonly used for very different conditions: certain antihistamines, including some sold over the counter for allergies or sleep; certain medications for overactive bladder; some antidepressants; some medications for nausea or stomach problems; some muscle relaxants. Many people taking these medications have no idea they have anticholinergic properties. The medication was prescribed for one thing, for a bladder issue, for sleep, for allergies, and the effect on the brain's acetylcholine system was not part of the conversation. The reason this matters specifically after 60 comes back to what I described earlier about the aging brain. As we age, the brain's capacity to produce and use acetylcholine declines naturally. This is a normal part of the aging process, and it contributes to the mild cognitive changes that many older adults experience. When a medication then additionally blocks the remaining acetylcholine activity, the cumulative effect can be more significant than either factor alone would suggest. Researchers have been studying what happens to cognitive function in older adults who take multiple medications with anticholinergic properties, sometimes called anticholinergic burden, and the findings are consistent enough and concerning enough that they've prompted major geriatric and pharmacy organizations to issue guidance about reducing this burden in elderly patients. This is not fringe concern. It's mainstream medicine catching up with something that was overlooked for too long. The signs, when they appear, can include exactly what I described at the beginning. Memory that seems less reliable, thinking that feels slower, difficulty with word retrieval, a sense of mental fog that comes and goes without an obvious explanation. They can also include confusion, particularly in situations of physiological stress, illness, surgery, dehydration, where the brain is already under pressure and the anticholinergic effect becomes temporarily more pronounced. If you are over 60 and you are taking any medications, including over-the-counter medications, for bladder control, for allergies, for sleep, for mood, for nausea, it may be worth asking your physician or pharmacist to review your full medication list specifically for anticholinergic load. That is a specific and reasonable request, and any physician familiar with geriatric medicine will know exactly what you're asking. There is a fourth dimension I want to address, and it's one that often doesn't get discussed because it requires understanding not just individual medications, but how they interact with each other. Polypharmacy. The simultaneous use of multiple medications. The average person in their 60s in many developed countries takes 5 or more medications daily. Many take considerably more. Each medication was, in most cases, prescribed for a legitimate reason by a competent physician. But what doesn't always happen is a systematic, regular review of the whole list, all the medications together, by someone whose primary concern is how they interact with one another, and specifically how that combination affects the aging brain. Drug interactions are complicated. They're not always predictable, and they're not always about medications intensifying each other's primary effects. Sometimes the interaction produces something neither medication would produce alone. A change in how sedating one medication feels, an effect on heart rate that alters blood flow to the brain, a change in how quickly another medication is metabolized, causing it to accumulate to higher levels than intended. Over time, these interactions accumulate in ways that are difficult to track without dedicated attention. A patient sees their cardiologist, who manages the heart medications. They see their internist, who manages blood pressure and cholesterol. They see a urologist who prescribed something for the bladder. They see a psychiatrist who manages sleep and mood. Each physician is doing their job. But no one may be holding the complete picture, looking at all of it together, asking what this combination is doing to the brain of a 68-year-old who has been taking all of these things simultaneously for 3 years. This is not a criticism of any individual physician or any individual decision. It is a structural reality of how medicine is often organized, and it is one that patients themselves may need to help bridge. Knowing your complete medication list. Bringing that list to every appointment. Asking, specifically, whether the combination is being reviewed. Requesting, if it seems warranted, a consultation with a pharmacist or a geriatrician whose specialty includes medication review in older adults. These are not passive things to wait for someone to offer you. They are things you can ask for. I want to talk now about the signs, the things to watch for in yourself or in someone you care about, because I think awareness at this level is genuinely valuable. The cognitive changes that can be associated with medication effects are, as I've said, subtle. They don't announce themselves dramatically. They arrive gradually, in a way that can be confused with normal aging, which is precisely why they're so often missed. What I've observed across many patients who eventually made the connection between their medications and their cognitive experience is a particular quality to these changes. They tend to be inconsistent in ways that pure neurodegeneration typically is not. There are good days and less good days. There are times of day when the mind feels clearer than others, often mornings before certain medications have been taken, or in the hours when a medication's peak effect has worn off. The variation follows a pattern, if you look for it, a pattern that aligns with the medication's presence and activity in the body. This is different from the cognitive changes of conditions like Alzheimer's disease, which tend to be more progressive, more consistent in their trajectory, less responsive to time of day or physiological state. I'm not suggesting that everyone who notices cognitive changes and takes multiple medications is experiencing medication effects rather than something more serious. I'm suggesting that the pattern of the changes, their variability, their relationship to the medication schedule, their quality, is information worth gathering and worth sharing with a physician. The signs themselves include things like difficulty holding a train of thought in a way that feels new, reaching for words that were once immediately available, reading the same sentence several times and still not quite retaining it, feeling like you're present in a conversation but not fully connected to it, a mental effort that seems disproportionate to the task, forgetting recent events with an ease that feels different from ordinary forgetfulness, feeling slow to orient in the morning, not in the normal waking up way, but in a way that persists longer than it should. None of these individually is alarming. Most people experience some of these occasionally. What makes them worth attention is their consistency, their gradual worsening over months, and their timing in relation to when medications were started, increased, or combined. Most people don't notice the pattern at first. They experience the symptom and explain it away. I'm tired. I've got a lot on my mind. I'm getting older. And then the explanation becomes a belief, and the belief makes the symptom invisible, and months or years pass during which something that might have been addressable is simply accommodated. I want to say something about how this conversation should happen, because I think the how matters enormously. If you are watching this and recognizing yourself, recognizing someone you know, in what I've been describing, I want to be very clear about what the appropriate next step is and is not. It is not to stop your medications. Please hear that clearly. I cannot say it strongly enough. Stopping medications that manage blood pressure, heart conditions, mood, or any other serious condition abruptly and without medical guidance can cause serious harm. The medications are prescribed because the conditions they treat are significant. The risk of those conditions going unmanaged is real, and in many cases considerably more serious than any cognitive side effect. What the appropriate step is a conversation. A specific, informed, persistent conversation with your physician or with a specialist in geriatric medicine or clinical pharmacy about whether your current medication regimen has been reviewed recently with cognitive effects specifically in mind, whether there are alternatives in any category that might be better tolerated from a cognitive perspective, whether any of your medications might be gradually reduced or discontinued if the condition it was originally prescribed for has changed or resolved. Whether the doses are still appropriate for your age, your weight, your kidney and liver function as they are now, not as they were 5 or 10 years ago when the prescription was written. These are legitimate medical questions. They deserve serious answers, and they are the kind of questions that sometimes don't get asked until someone, the patient, a family member, a particularly attentive physician, decides to ask them. I've watched patients, after this kind of careful review and adjustment, describe changes in their cognitive clarity that were, to them, significant. Not always. Not in every case. Sometimes the medications are reviewed, and the conclusion is that they're appropriate and well-balanced, and the cognitive changes have a different explanation entirely. But sometimes the review reveals something that was missed. A medication that had accumulated to too high a level. A combination that was producing an interaction no one had examined. A dose that was appropriate for a 50-year-old body and had never been recalibrated for a 65-year-old one. Those conversations, when they lead somewhere, feel to me like some of the most meaningful outcomes in medicine. Not because they involved heroic interventions, because they involved someone paying attention, asking the right questions, and having the information they needed to ask them. I want to step back from the clinical specifics for a moment and say something about what I think is the deeper issue. We live in a medical culture that has become extremely good at identifying problems and prescribing treatments for them. We are less systematically good at reviewing those treatments over time, at asking, as the patient ages and their body changes and their medication list grows, whether the original decisions still serve the original goals, at looking at the whole person, not just the individual conditions. This isn't a failure of medicine in some abstract sense. It's a structural challenge in how medical care is organized, and it's one that individual patients can, to some degree, help address for themselves by becoming more active participants in the conversation about their own medications, by knowing their full list, by asking questions, by paying attention to their own experience and taking that experience seriously enough to bring it to medical attention rather than simply accommodating it. The cognitive experience, how the mind feels, how memory functions, how sharply thoughts come and hold and connect, is not a trivial thing. It is, arguably, one of the most important dimensions of quality of life, and it is something that deserves to be preserved with the same seriousness that we bring to blood pressure numbers and cholesterol levels and bone density. It is something worth asking about, worth monitoring, worth advocating for. After 60, the body has changed in ways that require the medical decisions made for it to change as well. A medication regimen that was appropriate at 50 may need revision at 65. That revision should happen proactively, as part of routine care, driven by questions that patients feel empowered to ask, rather than only by problems that have become too large to ignore. As I bring this to a close, I want to leave you with something I hope is useful. Pay attention to your own cognitive experience with the same seriousness you pay to your physical symptoms. Notice whether the quality of your thinking has changed and when that change began. Notice whether the change is consistent or variable, and what the pattern of variability looks like. Notice whether it aligns with your medication schedule, with when you take things, with doses that have been adjusted, with medications that were added or removed. Bring that information to your physician. Not as a demand, not as a confrontation, but as the kind of careful self-observation that makes a medical conversation more productive. I've noticed that my memory feels different than it did 2 years ago. I'd like to understand whether any of my current medication